The headache was there when he woke up. It was there when he went to work. It was there when he tried to sleep. Every single day for 17 years. He was a man in his mid-30s, living an otherwise ordinary life. He had a job, a family, a daily routine. The pain was not dramatic, not the kind that sends someone to an emergency room. It was persistent, dull, and relentless. It sat behind his eyes and refused to leave. He had seen physicians. He had taken medication. He had been told it was tension. He had been told it was stress. He had been told more than once that some people simply live with chronic headaches. And so, for 17 years, that is what he did. But the symptoms did not stop. Over time, something began to change. The headaches grew more intense. There were moments of confusion, brief but noticeable. Memory became unreliable in ways that felt new. He described a feeling that something was not right, not just with the pain, but with his thinking. His family noticed it too. These were not the complaints of a man exaggerating discomfort. These were the signs of something progressing. He returned to physicians. More tests were ordered. Blood work, neurological assessments, standard evaluations. For years, the results had pointed to nothing definitive. If every scan and every panel came back without answers, perhaps the explanation really was psychological. That doubt, the kind that settles in after a decade of being told nothing is wrong, is one of the most isolating experiences a patient can face. He had carried it for nearly 2 decades. Then an imaging scan changed everything. A mass was visible in the brain tissue. It was not a tumor. It was not a lesion from a known neurological disease. It was a cyst. And inside that cyst, according to the medical records, was evidence of a parasite. Now here is where the medical records become unusual. The organism identified was consistent with Taenia solium, the pork tapeworm. What physicians were looking at was a condition called neurocysticercosis, a parasitic infection of the brain, caused by the larval stage of that tapeworm. It is the most common parasitic infection of the central nervous system worldwide, and it had been living, undetected, in this man's brain for what clinicians estimated was a very long time. Neurocysticercosis. The name describes exactly what it is: cysts caused by the Cysticercus larva, located in the nervous system. It begins not with a tapeworm in the intestine, though that is one route of infection, but with the ingestion of tapeworm eggs, typically through contaminated food or water, or through contact with an infected individual who carries the adult parasite. Once swallowed, the eggs hatch. The larvae migrate through the intestinal wall and enter the bloodstream. From there, they can travel to muscle tissue, the eyes, the spinal cord, or the brain. When they reach the brain, they encyst, forming a protective shell around themselves. Inside that cyst, the larva can remain viable for years. The immune system often does not recognize the threat immediately. The cyst wall mimics the body's own tissue in ways that delay detection. In some patients, the parasite causes no symptoms at all during this phase. In others, it causes exactly what this man experienced: chronic, treatment-resistant headaches, neurological changes, and cognitive symptoms that accumulate slowly over time. According to published literature, seizures are the most commonly reported symptom, but headache, hydrocephalus, and cognitive impairment are also well-documented presentations. What clinicians initially believed was a tension headache disorder or a stress-related condition had a structural, biological cause that standard headache workups are not designed to find. A routine neurological evaluation does not include imaging for parasitic cysts unless the physician has a specific reason to suspect one. Neurocysticercosis is classified as a neglected tropical disease by the World Health Organization, meaning it is strongly associated with regions where sanitation infrastructure is limited and where undercooked pork is consumed. In countries where the condition is rare, it is rarely considered. Research indicates that diagnosis is frequently delayed by years, sometimes decades, in patients who present in regions where physicians have limited clinical exposure to the condition. When the cyst is active and the larva is alive, the immune system may not respond strongly. But when the larva dies, either naturally or as a result of treatment, the immune system suddenly recognizes the foreign material. The inflammatory response that follows is often what causes the most acute neurological symptoms. This is why treatment requires careful coordination. Anti-parasitic medications must often be paired with anti-inflammatory agents to prevent the immune response from causing additional damage to surrounding brain tissue. According to published case literature, this treatment window requires close monitoring. In documented cases where the cyst is solitary and accessible, outcomes following treatment have been reported as favorable. The inflammation resolves. The headaches, in many cases, diminish significantly. And then came a finding that changed how physicians understood this. What this case and the broader medical literature surrounding neurocysticercosis exposes is a gap that exists at the intersection of clinical geography and diagnostic assumption. The medical system is designed, in part, around probability. A physician working in a setting where a parasitic brain infection is statistically rare will not consider it as a first explanation for chronic headaches. That is not negligence. That is how differential diagnosis works. But when global travel and migration mean that patients may have been exposed to pathogens far outside the epidemiological profile of their current location, probability-based medicine can leave patients undiagnosed for extraordinary lengths of time. The World Health Organization has identified neurocysticercosis as a major public health concern in regions of Latin America, Sub-Saharan Africa, and parts of Asia. Globally, researchers estimate it is responsible for a substantial proportion of adult-onset epilepsy in endemic areas. In documented case series, patients have reported symptom durations ranging from months to, as in this case, multiple decades before the correct diagnosis was established. Studies using MRI and CT imaging have allowed clinicians to stage the condition, identifying whether the cyst is active, transitional, or calcified, which directly informs the treatment approach. What medicine still cannot fully explain is why some individuals with confirmed neurocysticercosis experience severe neurological deterioration, while others remain asymptomatic for years. The relationship between cyst location, immune response, and symptom severity is not yet fully characterized. Researchers continue to investigate why the inflammatory cascade, once triggered, causes such variable outcomes across patients. For this patient, the end of 17 years of pain came not from a new medication for headaches, but from the correct question finally being asked. What is actually causing this? The answer required imaging. It required a physician willing to consider what had not yet been considered. And it required recognizing that a headache, even a quiet and persistent one, is sometimes the only outward sign of something far more significant occurring inside the brain. The headache was there when he woke up. Every single day for 17 years, it was there. And then finally, someone looked more closely. The cause was not stress, it was not tension. It was a medical case that had been present the entire time, waiting to be found. This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician. Medical mysteries. True cases every week